neonatologist at the University of Rochester, and am excited to be able to introduce you to our 2022 Bond Scholars this year. This is the 10th year that we've had the AAP Bond Scholar Program, and this is a award program that's made possible by generous support from both the section on neonatal perinatal medicine and also the Vermont Oxford Network. These awards are a way for us to recognize neonatal fellows and early career neonatologists who are committed to a career in quality improvement. This year, the AAP Bond Scholars actually did present in person at the annual Quality Congress in Chicago for the first time, and it was a really wonderful forum for us to hear about their work and to promote networking within the QI world. But we also wanted to make sure to highlight their amazing accomplishments virtually for those who may have missed their talks at the AQC. And we have for the past 2 years done a virtual presentation of the AAP Bond Scholars and had some great feedback from it. And so we're excited to share that with you again today. Today I have listed here our agenda. So we have 5 AAP Bond Scholar presentations. For each of them, I'm going to give a quick introduction before they talk, and then they're going to let you know about a specific aspect of their quality improvement projects or their quality improvement interests. And then at the end, we're going to have 30 minutes for questions and answers. And so if you could use the chat function to put your questions in as you think of them, as you're hearing the presentation. I have asked the scholars to not answer those questions in the chat as they come in necessarily the entire time, just so we have some things to actually talk about in person. But please go ahead and put those questions or comments in as you hear the presentations happening. And so I am going to go ahead and get us started with our very first presentation. It's going to be by Dr. Chandi Ravikumar. Dr. Ravikumar is a third-year fellow in neonatal perinatal medicine at the University of Texas Health Science Center in Houston. She obtained her bachelor's degree in biochemistry at the University of Texas at Austin. And she had a brief career in health information technology when she worked as an electronic medical record software specialist before medical school. She obtained her medical degree from the Texas College of Osteopathic Medicine, where she fell in love with the NICU during her clerkship. She completed her pediatric residency at the University of Texas Health Science Center in San Antonio. And during training, she participated in resident quality improvement curriculum and workshops to learn QI methodology. She also championed an interdepartmental QI project to improve the timing of antibiotic administration in febrile neutropenic patients in the ER. She's particularly interested in using her background in healthcare information technology to optimize EMR utilization and patient care, safety, and research. And after completing her fellowship, she hopes to become a leader in her community on quality of patient safety and neonatal care. Please join me in welcoming Dr. Ravikumar.
All right. Thanks, Colby. And I'd like to thank the AAP and Bond Scholar Program for inviting me to speak today. I will be presenting our hospital's QI project on delayed cord clamping in the newborns in the delivery room. I have no disclosures. So just to kind of have an understanding of what our hospital is like, Children's Memorial Hermann in Houston is a level 4 NICU. We have about 118 beds, and we see about 5,000 deliveries at Hermann each year. We see many complex and high-risk deliveries due to our very active fetal center. The impetus for this project really originated with the new 8th edition NRP update to the 4 pre-birth questions, which now include, what is the umbilical cord management plan? As we all know, robust evidence has suggested that delayed cord clamping has several benefits in infants of all gestational ages, and NRP currently recommends 30 to 60 seconds of delayed cord clamping in vigorous infants. The baseline delayed cord clamping rate was really hard to obtain for our pre-intervention data due to challenges with data retrieval from paper charting and just overall poor documentation of this data. Through the Neonatal Research Network, we do collect data for infants less than 29 weeks, and less than 10% of this population received delayed cord clamping before our QI initiative. So we followed QI methodology to develop our project. The two biggest problems identified were that the timing of clamping the umbilical cord varied amongst obstetrical teams at Herman. Additionally, there's inconsistent documentation of this data in the delivery record. We then created a pre-intervention process map to understand on a granular level all the roles and responsibilities from the moment that L&D notifies OB of the impending delivery to documentation of the delivery record. This process map was used as a foundation to incorporate our QI interventions into the current workflow. We then created an Ishikawa fishbone diagram to identify potential limiting factors in achieving delayed cord clamping. The main categories identified were thermoregulation, the patient, labor and delivery team, delayed documentation, equipment, and the NICU team. We then created a SMART aim. Our aim was to achieve delayed cord clamping in 60% of all vigorous infants at Herman by December 2022. And we defined vigorous infant as an infant who is breathing or crying with stimulation and or has adequate tone. We then identified several primary drivers to help us achieve our aim, including education, awareness and buy-in, communication, documentation, and patient safety. And using all of that information gathered, our team sought to develop interventions to increase the delayed cord clamping rates. So this slide has a lot of information, but it depicts the PDSA cycles and a run chart describing the proportion of infants that received delayed cord clamping on the y-axis and the months on the x-axis. Our goal is the blue line at the top, which is 60%, and our median delayed cord clamping rates for all gestational ages is 48%. So just to kind of give you a timeline, this project was conceived in the fall of 2021, and we really focused our pre-implementation period on stakeholder buy-in, stakeholder input, and lots of education. Our first cycle was implemented in February of this year. Our first intervention was to develop an existing L&D and NICU communication tool that was to include the new pre-birth question about delayed cord clamping. So we really just wanted to start getting the question out there and OB and NICU teams communicating prior to the delivery of if these infants would receive delayed cord clamping or not. Through that first intervention, we saw about 50% of all of our infants receiving delayed cord clamping. The second cycle was implemented in April of 2022. In this cycle, we developed a delayed cord clamping protocol and posted it in each resuscitation area in the C-section rooms and the laboring rooms to kind of define roles and responsibilities of how to kind of roll out the delayed cord clamping procedure. With these two interventions, we found that the teams felt comfortable communicating the plan prior, but both the NICU and the OB and labor and delivery teams felt pretty uncomfortable communicating during and monitoring the infant during the delayed cord clamping process. As you can see, there's a dip in our delayed cord clamping rates in June of 2022. We kind of looked at the documentation and reasons that delayed cord clamping was not performed in our infants. We noted that 20% included patient factors and 10% were OB decision or they forgot to perform delayed cord clamping. The rest of, and for 50%, there was no reason provided for not performing delayed cord clamping. So currently our team is in the third PDSA cycle. We are working on developing and validating a standardized script to facilitate communication based off of feedback that we received in a survey given to our NICU staff. So there are many challenges in doing this QI project in the delivery room, including the mom and baby dyad, varying personnel, difficulties with accurate and efficient delivery room documentation, and working with interdisciplinary teams. We hope to address these challenges by using the EMR to address data acquisition. And we have identified stakeholders in the OB department and the nurse practitioner department to address the problems that varying personnel in the delivery room can have for our project. I really like to thank my mentor and my co-project leader, Dr. Chiamaka Niji. This project would have been very difficult to achieve without her. I have several other people I'd like to thank in the NICU and L&D nursing departments that have helped achieve this project's goal. Also like to thank Dr. Rice-Savvy in our NICU department and Dr. Blackwell for providing support for this project. Thank you.
Thank you, Dr. Ravi Kumar. That was an excellent presentation. Our next Vaughn Scholar who is going to be presenting for us today is Dr. Anjali Anders, who is an assistant professor of clinical child health at the University of Missouri in Columbia. She completed her medical school and residency at the University of Missouri Columbia. And following this, she completed her neonatal perinatal medicine fellowship at Vanderbilt University, where she developed an interest in quality improvement. This interest has continued into her work as a clinical neonatologist, and she co-leads or leads multiple initiatives at this time. One initiative she leads is to decrease the incidence of chronic lung disease among preterm infants, and her QI team utilized high-fidelity simulation to demonstrate and record the implementation of bubble CPAP in the delivery room to educate physicians, nurses, and respiratory therapists. Dr. Anders has completed the Intermediate Improvement Science Series through Cincinnati Children's Hospital, and she applies knowledge from this course to her other quality improvement initiatives. Dr. Anders serves as the NICU QI director at Women and Children's Hospital and was recently elected co-chair of the Missouri Hospital Association Maternal Child Learning Action Network, which is a perinatal QI collaborative. Through her projects and her leadership roles, she strives to increase interest in quality improvement among other healthcare professionals and aspires to build a culture focused on providing the safest and most effective care for patients. Please join me in welcoming Dr. Anders.
Thank you so much, you all, for allowing me to come and talk today. So I will be discussing the use of high fidelity simulation to drive quality improvement. And I have no financial disclosures. So to start, I just want to give a quick review on just BPD, or bronchopulmonary dysplasia. So BPD is associated, as we know, with increased risk of neurodevelopmental delays and mortality. And invasive mechanical ventilation significantly increases the risk of BPD. CPAP use is beneficial in decreasing risk for development of BPD. And QI methodology, along with use of high fidelity simulation, can be utilized to create an efficient process of bubble CPAP implementation in the resuscitation room. So where we started with our QI was to kind of collect some baseline data. So this data is from 2018 for all infants less than 32 weeks gestational age who were inborn at our hospital. And this figure shows that the lower gestational age at birth is associated with longer duration of respiratory support use. And I think this is pretty commonly seen at other centers also. In this figure on the y-axis, you have the the corrected gestational age when respiratory support was discontinued. And these groupings, the first 4 bars are infants born at less than 28 weeks at birth. The next grouping is 28 to 29 weeks, 30 weeks, and 31 weeks. And the blue bar illustrates when infants were first weaned off CPAP to a lower level of support. The orange is when they came off of CPAP. The gray is when they're kind of maybe going back and forth from high flow and CPAP. And the kind of lighter orange is when they finally come off respiratory support. So you can see our infants less than 28 weeks were more likely to be on respiratory support until approximately 36 weeks on average, while our infants at 31 weeks at birth were able to come off at around 33 weeks corrected age. Through this, we developed our key driver diagram with a goal of, as I mentioned, the global aim was reducing chronic lung disease among preterm infants. Our initial SMART aim was to increase the use of bubble CPAP with an occlusive nasal interface in the resuscitation room for preterm infants less than 32 weeks gestational age from 0 to 50% within initiation of the guideline. Within 6 months of initiation of the guideline. And as you can see, we had several key drivers, some of which were talking about standardized use of surfactant, what type of interface we used, and then also trying to keep the infants on CPAP for positive pressure as opposed to high flow, how long we're keeping the infants on CPAP, making sure we perform a Rumera trial at 36 weeks if infants are on non-invasive support. And so the first one I'll be talking about is the intervention use of high fidelity simulation in a mannequin, along with our resuscitation equipment to standardize the process of bubble CPAP commencement in the delivery room, and using an occlusive interface when we do. So just to talk a little bit about our PDSA cycles. So the first one involved evidence-based practices being reviewed and a guideline being developed. Our second PDSA cycle was performing sequential in situ simulations using a high fidelity mannequin with resuscitation equipment to standardize the process of bubble CPAP commencement in the delivery room, which I'll talk about a little bit more in a minute. And then the third PDSA cycle was use of bubble CPAP in the resuscitation room on actual preterm infants. And an educational video was provided to all NICU staff to review prior to the initiation of use. And most recently, we've created an equipment form to allow for consistency of available equipment for the resuscitations. Due to inconsistent stocking for some of the equipment led to some difficulties in available equipment when we were beginning resuscitations. So just a little bit more on the in situ simulations that we were doing. So we utilized a high fidelity mannequin to simulate grunting and apnea. Vital signs on monitors were used to reinforce effective versus ineffective CPAP. Initially, we used a flow inflating bag from the radiant warmer and bubble CPAP on a transport pole to provide PPV and bubble CPAP respectively. The process was recorded and an educational video was provided to staff on the application of bubble CPAP and transition to PPV if necessary, as per NRP guidelines. Upon repetition of the simulation, we discovered that there was limited oxygen and air supply outlets in some of the delivery rooms. And with that setup, suction apparatus was not functional. So then we actually transitioned to use of T-piece resuscitator along with bubble CPAP available simultaneously, both attached to the radiant warmer, and that allowed for either support to be available, one for bubble CPAP and one for PPV if the infant needed. The video was also edited and published in near reviews to provide hospitals outside of our institution with a way of incorporating bubble CPAP efficiently into NRP and delivery room resuscitations. So these next few figures kind of show some of our data that we've been looking at. All of them have the percent patients on the y-axis, and along the x-axis in chronological order, we have groups of ends of 5. So this first figure shows the percent of preterm infants with use of bubble CPAP in the resuscitation room. And this includes any infants under 32 weeks. So we are very excited that we went from 0% using bubble CPAP to 60% since we've started this and continuing to improve. And the reason we used both groups, we wanted more infants to go onto bubble CPAP with the occlusive nasal mask interface as opposed to RAM, and less infants hopefully requiring intubation also. This figure is looking at the percent of infants on 21% FiO2 at 28 days of life, hopefully as an early marker of infants less likely being or developing chronic lung disease by 36 weeks. And as you can see, we went from about 60% to 80%. This next figure is looking at the percent of infants placed on any invasive mechanical ventilation. And so we are still a work in progress, but have gone from 60% to 40% of infants since the start of the QI. Our goal is still hopefully to get back below 25% and continuing to see even fewer infants requiring invasive mechanical ventilation. And this last figure is the percent of infants requiring any respiratory support at 36 weeks. So an official definition of chronic lung disease or BPD in this population. And I wish we could say we have seen a significant shift, but we are still a work in progress for this part. And I know several QIs out there, it takes a couple years, but so we're still kind of working on seeing a significant shift in this, but hoping we'll start seeing that here within the year. So the last few slides, I was just going to talk about how we end up improving buy-in and just kind of talking through things that we've learned through our processes. So one of the ways we've worked on improving buy-in was using patient examples to discuss how current and past management may have affected outcomes. And we kind of show patient examples without actually utilizing their names, but just kind of showing how their course went compared to what our current evidence-based practice is. With our change in practice, staff also have come up to me noticing that infants have less work of breathing and fewer infants are requiring invasive respiratory support, which seems to improve buy-in over time. Our use of high fidelity simulation with the available educational recording allowed it for staff to be able to prepare for deliveries and make it easier for use whenever they start incorporating bubble CPAP into NRP, which was a positive change for us. Lastly, I would like to thank the Vaughn Network and Vaughn Scholars Program, Mary Ann Link for her mentorship in the Intermediate Improvement Science Series course from Cincinnati Children's, Dr. Akshay Vacharjani for his mentorship, our whole QI team at University of Missouri Columbia, along with all of our NICU staff, and Elizabeth Duplessis from our Center for Education Development for editing all the videos that we created for educational purposes. Thank you.
Thank you, Dr. Anders. That was great. Our next AAP Vaughn Scholar is Dr. Rochelle Reinhardt. Dr. Reinhardt is a third-year neonatology fellow at Children's National Hospital in Washington, D.C. She completed her undergraduate degree in biomedical engineering at Georgia Tech, medical school at the University of South Florida, and pediatrics residency at Rainbow Babies and Children's Hospital. Dr. Reinhardt has been involved in quality improvement and patient safety research since medical school, ranging from work in improving multidisciplinary care in neonatal abstinence syndrome to studying the effects of virtual rounding in the COVID-19 pandemic to monitor bundle compliance and engagement. She completed her white and yellow belts in lean certification and is currently enrolled in a master's in healthcare quality at the George Washington University with the hopes of pursuing a leadership position in QI after the completion of fellowship. Please join me in welcoming Dr. Reinhardt.
Thank you so much. And thank you again to the Vaughn program for allowing us to be here to present on our work. I'm really excited to present also on behalf of one of the infectious disease co-fellows, Mari Sue, as well as our mentor, Dr. Hamdi. I have no relevant disclosures to discuss. So first, just a note about Children's National NICU, where I am. We are a 70-bed level 4 NICU that serves the DC area as well as Virginia and Maryland, so a wide catchment of patients. We have, of course, all specialties as well as surgical subspecialties and ECMO. We are an exclusively outborn population, which is a reason why my project is a little bit different than some other projects that have been done in antibiotic stewardship, just kind of looking at how the babies are not coming directly from our delivery unit. So of course, as we all know, antibiotics are one of the most common medications that we use in the NICU. And so therefore, we're at high risk for overuse of them. Our babies could have severe consequences to infection. So many people will use them kind of more quickly than not. And that's because our babies are vulnerable, especially our premature babies are immunologically immature. However, more recently, there's been new research that's coming out showing there are immediate and long-term effects of antibiotics, some of which are written over to the right. I'll just highlight that babies who have received antibiotics are at higher risk for NEC, as well as higher risk of mortality and morbidity. And then later on in childhood, there are effects on obesity, as well as increased rates of ATP. For that reason, I knew that I wanted to look at the antibiotic use in our NICU. And so I first started out by creating a Pareto chart, looking at my baseline data, which is the ending months of 2020, and to look at what diagnoses we use antibiotics for. And very unsurprisingly, early onset and late onset sepsis rule out were the most common diagnosis. In order to really narrow the focus of my project, I'm looking specifically at early onset sepsis. So the global aim is to overall implement a program to reduce the antibiotic-related harm in our NICU. And the way that I'm going to do that, and by decreasing antibiotic use, is by looking at the median number of hours of antibiotic exposure per NICU baby who is diagnosed with early onset sepsis rule out. And I would like to come down from 47 hours, which is our baseline, to 38 hours, which is a decrease by 20% by the end of this year. This is a picture of our KDD, so our global and specific aims are written over to the left, like I discussed. The key drivers really are our provider comfort and the practices that we use in our unit, as well as the clinical practice guidelines that we use and the electronic medical record, which we know the practices related to that are heavily influenced when looking at antibiotics. The interventions are listed to the right. I'll go through more specifically some of them in detail. So first, talking about the measures. So the primary outcome, as I said, is the median number of hours that babies are exposed to antibiotics for early onset sepsis. The secondary outcome is grayed out because I just don't have the data to present at this point, but we're hoping to look at antibiotic-related lab draws. So for instance, gentamicin levels. Our process outcomes are the percentage of rule-outs that are greater than 36 hours and greater than 48 hours. And I just want to take a moment to pause here and discuss again how all of our babies are outborn. And the data that I am using and presenting is our pharmacy data. So that means it's only the antibiotic dosages and hours that the babies got once they got to us. And that's most typically in addition to at least one dose at an outside hospital. So just a little bit different. Our balancing outcomes, many antibiotic projects look at the mortality from sepsis. Hopefully that number is very, very low. So I'm looking at a few secondary balancing measures, including the number of positive cultures after 36 hours, as well as the length of stay. So back to our KDD, we're going to specifically talk about interventions. Of course, the first intervention was, extensive education to all of our faculty members, our nurse practitioners, our fellows, as well as creating a multidisciplinary team that involves pharmacy and nursing in order to spread that education. And next, we worked on a algorithm that limited early onset sepsis rule-outs to 36 hours from our previous 48 hours. And this algorithm splits babies into two preterm and late preterm and full term. On the right side, the late preterm and full term really follows the Kaiser early onset sepsis risk calculator that I'm sure many of you are familiar with, that ultimately just leads you to deciding doing culture or antibiotics or neither. And then the left side for the preterm babies, this really divides babies into low risk and high risk babies. And so the low risk are those that are more typically delivered for maternal reasons and you're less concerned about an infection. But ultimately, all of these babies come back to hopefully discontinuing the antibiotics at 36 hours, of course, if the baby is well appearing and has a negative culture at that time. Next, I just wanted to mention another intervention was a project that was occurring simultaneously from our second year fellows. And that was really looking at the documentation of blood culture volumes that are obtained at the outside hospital. As I said, since all of our babies are mostly started on antibiotics and at least got the culture at the outside hospital, there is sometimes a lower risk of trust of the culture being obtained in a manner that we feel is truly negative. And so there could potentially be more culture negative sepsis treatments because the culture wasn't obtained with us, and we don't really know, was it obtained properly or was there enough blood? So our second years looked at documenting that blood culture volume to ensure increased trust when we have the babies here, that the negative culture is truly negative. And so they did a few PDSA cycles looking at that documentation and ultimately got 100% of our babies on the transport information documented that the blood culture was obtained and looking at the volume. So to look at our baseline data and then results, so those first couple months that I used as both baseline, there were 135 courses. And as I said, the median was 47 hours of exposure, and this is of combined gent and ampicillin. About a third of our babies were experiencing greater than 48 hours here, and about 70% were getting greater than 36 hours. After intervention, we have 303 courses over most of this year. It's May to September is the data that I have at this point. The median number of hours has come down to 40 hours. We have less than 20% now that are experiencing greater than 48 hours of antibiotics here, and still about 62 that are greater than 36. So we certainly still have opportunity for improvement. The next two charts that I'll show you are broken down into, this one is just ampicillin and the next is just gentamicin. This is my XMR charts that are looking at each of these antibiotics. The horizontal axis is each individual patient associated with the number of hours of antibiotics that they received. And you can see the baseline to the left and then the few interventions that I mentioned kind of annotated throughout. This is the gentamicin curve or XMR charts. And you can see similarly written out. I think that there is less variability in the hours given of gentamicin due to the longer frequency that gentamicin is given over. When it's dosed at 24 and 36, there's kind of less opportunity to reduce that number of antibiotics versus the ampicillin. And looking at some of the balancing measures, so our length of stay has not changed pre and post intervention. And so far, the baseline data had no positive cultures after 36 hours. We are currently in the process of obtaining that secondary baseline for our post intervention data. The next steps that I'd like to take, so ultimately getting to a place where we hopefully could have hard electronic stops at 36 hours and possibly get somewhere where we are not starting antibiotics at all for those low risk patients, preterm patients. And a big one for us will be addressing antibiotics that are given at the outside hospital so that we can ensure that babies are not getting more antibiotics than they truly need. Of course, continuing to collect secondary and baseline balancing measure data and doing the analysis using the XMR charts. I'd really like to thank again the program as well as the rest of my team for all this wonderful work that we've been able to do here. Thank you so much.
Thank you, Dr. Reinhardt. That was great. Our next AAP Von Scholar we're hearing from today is Dr. Priyanka Tiwari. Dr. Tiwari is an attending neonatologist at the New York Presbyterian Alexandra Cohen Hospital for Women and Newborns. She obtained her BA in psychology from Johns Hopkins University and her medical degree from the New York Medical College. She completed her pediatric residency at NYU Health and her neonatal perinatal medicine fellowship at Weill Cornell Medicine. She is a 2020 graduate of the Quality Improvement Academy, working on a project focusing on identification and management of asymptomatic hypoglycemia in high-risk neonates. As the Director of Quality Improvement in the NICU, Dr. Tiwari serves as a QI advisor and a leader for multiple initiatives, and has created multidisciplinary collaborations within the division and across departments. Her future career goals are to use her unit's data in comparison to benchmarking data provided by Vaughn for other centers similar to her own unit to help identify continued local opportunities for improvement, to extend her QI efforts and impact through multi-center collaboratives on a regional and national level, and to educate and mentor future generations of quality improvement physician scientists. Please join me in welcoming Dr. Tiwari.
Thank you so much, Colby, and thank you to the AAP Von Scholars Program for giving me the opportunity to speak today about a quality improvement initiative that our team has been working on for the past few years, reducing unplanned extubations in a level 4 NICU and the lessons I've learned along the way. I have here the QR code for many of the documents that we used during the initiative, and I'll show this at the end as well for people to be able to look at it in detail at their own pace. I have no disclosures. Unplanned extubations are a frequent problem in neonates for many reasons. Neonates have short tracheal distances. Providers often use sedation cautiously, especially in the preterm population, given the neurodevelopmental implications. And excessive secretions and immature skin integrity make endotracheal tube securement difficult. An unplanned extubation can lead to undue complications, such as increased oxygen consumption, prolonged hospital stay, need for CPR, and even death. Our unit identified this as a major safety initiative that we needed improvement on, as we had some months where we were 5 times the benchmark goal of less than 1 unplanned extubation per 100 ventilator days. For context, our unit is a 60-bed, single-room academic level 4 regional perinatal NICU, where about 700 babies are admitted annually, including both inborn and outborn referrals. The average ventilator days per month is approximately 160. Up top here is a picture of the lobby of our hospital, and the bottom is a picture of one of our single rooms. After attending actually the 2019 Vaughan Quality Congress and the Solutions for Patient Safety meetings, I was really struck by the work that was being done at other children's hospitals and sought to adapt a model that worked in other units. The first lesson I learned was the importance of identifying key stakeholders in the many different disciplines, including quality and patient safety specialists, nursing, respiratory therapists, family advisory council members, radiology techs, neonatal nurse practitioners, neonatal fellows, and attendings that were invested in the outcome, and having each group be responsible for different aspects of the initiative. Once the champions were identified, the next step was to convene them to identify the primary and secondary drivers that would help achieve our SMART aim. The primary drivers that were identified were endotracheal tube placement and securement, our workflow, and our culture. We then went on to identify numerous secondary drivers and derived interventions that address these specific drivers, displayed here in this key driver diagram, and I'll go over some of these interventions in detail. Another key lesson learned here was the importance of identifying a family of measures and creating a systematic plan to monitor that data and review it at regular intervals. Our outcome measure was the number of unplanned extubations per 100 ventilator days. Our process measures was the compliance with the unplanned extubation care bundle, which was adopted from SPS, and the completion of a parent cause analysis form, whose questions we came up with as a multidisciplinary group to identify the key risk factors that may contribute to an event. Both of these documents can be accessed with these QR codes here. The balancing measures were respiratory device-related pressure injuries and other hospital-acquired conditions, as has been demonstrated in the literature that focusing on one initiative may inadvertently increase other hospital-acquired conditions. We used a model for improvement and multiple sequential PDSA cycles with small iterative changes over time. A huge lesson learned here was that change takes time to happen, and there were multiple PDSA cycles we had to implement to demonstrate a change that was sustained. In the first cycle, we sought to accurately capture our data and inadvertently realized that the introduction of inline suctioning, which was not a planned intervention, may have affected our unplanned extubation numbers. In cycle 2, we identified gaps in our multidisciplinary team and identified further staff champions, performed nursing and RT education specific to the inline suctioning, and RTs began to routinely perform audits and fill out ACA forms after events. Based on these ACA forms, we identified tube securement as a major cause of events. So the unit underwent education regarding standardizing ETT taping with the creation of education materials. In cycle 4, we initiated real-time post-event debriefs with the frontline staff, implemented the bedside airway cards that outlined high-risk procedures and the need for at least 2 people at the bedside during these procedures, and conducted divisional root cause analyses when there was a string of events that occurred. And lastly, in cycle 5, we standardized the post-extubation debrief with a series of questions that the team would ask to help create a shared mental model following the event, and created personal bedside airway cards that said where the ET tube was secured and hung at bedside that was ultimately combined with the bedside airway cards in cycle 4 to reduce sign fatigue. Here is a U-chart demonstrating our outcome measure of unplanned extubations per 100 ventilator days on the y-axis and the months on the x-axis. Our baseline center line from January 2019 to June 2019 was 2.3 events per 100 ventilator days. And once we had a multi-pronged approach to capture events, along with the introduction of inline suctioning, our center line inadvertently increased to 4.7 per 100 ventilator days. Following cycle 2, we were able to see a drop in our center line to 1.9 per 100 ventilator days, with a further drop in the center line after cycle 5 to 0.4 per 100 ventilator days, achieving our goal. This data was presented monthly divisionally and across the New York Presbyterian enterprise, allowing for both accountability as well as fueling excitement about the tremendous progress that was made over time. To even further demonstrate the impact that this had on our unit, in 2019, we had a total of 80 unplanned extubations. In 2020, we had 69. In 2021, we had 25. And so far in 2022, we've only had 4 unplanned extubations to date. In conclusion, a multidisciplinary QI team with sequential efforts is necessary to address a multifactorial safety event and sustain a culture change. Our next steps will be the introduction of family K cards and preparation of our manuscript. And we're using a similar approach for other hospital-acquired conditions in our unit, such as CLABSIs, given this project's success. And as with all QI initiatives, it takes a village. And here are just some of my acknowledgements. Dr. Emily Ahn and Dr. Sean Cullen in particular were the neonatal fellow leads on this project, without whom this project could not have been possible. And please feel free to access our documents using this QR code, and feel free to email me with any questions or comments.
Thank you, Dr. Tawari. That was wonderful. We have our final AAP Von Scholar presentation coming up now. That will be Dr. Maria Franco-Fuenmayor, who is the neonatologist at the University of Texas Medical Branch in Galveston, where she also completed her medical school, pediatrics residency, and neonatal perinatal medicine fellowship. During her postgraduate training, Dr. Franco-Fuenmayor realized her passion for quality improvement in neonatal care and sought to improve her skills through participation in the TCAN QI Summer School and then the IHI Open School Basic Certificate in Quality and Safety. Throughout her training, she was actively involved in the creation and implementation of multiple QI projects in the NICU, including improved surfactant administration and diagnosis with lung ultrasound, neonatal iron supplementation dosing, and antibiotic stewardship. She has presented her work at various local, state, and national conferences. Dr. Franco-Fuenmayor is a firm believer in the importance and impact of innovation through multidisciplinary teamwork grounded in QI methodology. She serves as a team leader for Home Safe, a multifaceted project that we're about to hear about in her presentation about safe discharge of high-risk infants. And she's a strong advocate of family-centered care and has helped weave its layer into her Home Safe project. She is also an active participant in the Family-Centered Care Task Force, and she enjoys collaborating with her colleagues to create a widespread culture of teamwork and family integration that improves overall neonatal care. Please join me in welcoming Dr. Franco-Fuenmayor.
Good afternoon. Thank you again for that warm introduction, and again to the Von Scholars Program for allowing me to present my work. We're going to take a little journey as to how we launched this multidisciplinary project for Home Safe. And so I have nothing to disclose. So as we all know, there are several steps that we should take in order to launch a successful QI project. And so as we go over the next few minutes, we're going to go through each piece of how Home Safe is weaved into this. And so we're going to go ahead and start at really identifying our problem. And so when this work began for me, I was still a neonatal fellow sitting in the high-risk clinic. And as many of you know, we spend lots of hours at the bedside. And one of the things that was very frustrating was feeling like when babies were arriving to our high-risk clinic, there seemed to be some gaps in care. And we all know that discharge of really high-risk infants from the NICU really requires a standardized discharge process. And so we felt that that was one of the avenues that was really lacking. And so we grounded our work in really the global aim from the SPEECH criteria and how are we going to tackle this? How are we going to address this? And so we found that some of the big gaps really included parental knowledge and involvement, handoff and appointments, even medication education. And so once we realized that, this wasn't just a individual problem, but rather that the whole staff was really feeling this burden, we queried them and we said, okay, where are the gaps? Where are the things that we need to close so that we make this safe for our babies? And so that leads me to really step 2, right? Who do you involve? We have a big level 4 unit that has lots of moving parts on any given day. And so it really, started to become a discussion of who do we get involved. When you're talking about a multidisciplinary QI project, you really need to start identifying who are the stakeholders. And to identify those stakeholders, you need to figure out who are the individuals in your unit who share those same goals and who understands the current dynamics of the unit. Because that is going to be an implementation barrier that you can be able to identify. The other beautiful thing, and that's my home safe team right there, is that they not only can help you identify the gaps that are occurring, they're also going to help you identify what areas could you run into when you try to implement any of these things. And so as you can see, our team includes individuals from all of our unit to really target this multifactorial aspect of discharge. And so we created our driver diagram. And so we, like I said, founded ourselves on the SEEPS criteria for using home safe to discharge all infants from our NICU by January of 2023. And so we identified 4 primary drivers. And as we all know, those drivers can fluctuate. They're all interrelated to one another. We really wanted to have discharge standardization, really hone in on our communication, while also considering family-centered care and health equity. And as you can see, those secondary drivers are all weaved into all of these pieces because they're really all interrelated. When you're trying to discharge a high-risk infant, all of those pieces really need to align and work together in order to make it successful. And so what did we do? And so we know that in neonatology, we all love a good acronym. So I gave it an acronym. I said, how are we going to put a name to this problem, to this issue that we're all having? It's affecting the staff, it's affecting the families, and there's repercussions about healthcare utilization and whether they're being appropriately referred to the correct clinics. And that's really how Home Safe was born. And so Home Safe stands for handoff, order reconciliation, medications, equipment, summaries. Those include both discharge and OT summaries, the appointments, the family involvement, and the education. And so ours, we decided to pick a start date, and we began in actually September of 2020, peak COVID time. We just celebrated our 2-year anniversary, and we started meeting just monthly. One of the initial things that we really realized from the get-go was we needed a team leader. So who could guide those conversations? And I stress this point because as you have multidisciplinary teams, those teams can grow to be rather large, and you want to make sure that everyone has a voice, but at the same time, make sure to gear the conversation back to sort of those tasks of that meeting hand. And so if not, you can start delving yourself into multiple tangential points, which may be important, but may not be the key focus of what you're trying to tackle at that moment. And really remaining realistic and flexible about the time frame that it takes to implement these things. One of the things that you'll see here is we focused on trying to, how can we tackle this? How can we organize this? We really need a discharge checklist. How can we integrate the EMR to really make everything seamless for our staff so that would translate to our outpatient clinics? This took many months. I'm sure all of you know that getting IT to load things into the EMR and getting it all loaded is a fairly complex process. And even after we launched it, it took 3 revisions before, 3 revisions afterwards. And so I would encourage you that when you're launching these big initiatives, that you pick a way to test those changes. For us, that came through our PDSA cycles. And I've put on this slide the beginning PDSA cycles that we started off with. I think my current table list is almost at 30. We decided to pick PDSA focuses for each of us. And so we decided to look, the first thing was a teamwork initiative, and that was building algorithms that would tackle the safe discharge of our babies. For us, that happened to be distributed into who was going to be followed in the high risk clinic with the fellows and the neos, and who was going to be followed at our other outpatient clinics. And so we stratified of greater than 32 and less than 32 weeks. And then we really started honing in on where are the other issues? How do we educate the staff? How do we put everything on the EMR? How do we get the families involved? And so this is something that I would encourage that as you're building those changes, you find a way to circle back and really make sure, are those things working or are they not? And so I've mentioned a little bit about the discharge checklist. And so I said we started this smack dab in the middle of COVID, right? Everyone's bandwidth is limited as far as to what they can actually do and implement. The beautiful thing about it is when you have a huge team, you can really play to everyone's strengths. and everyone's time for that matter, and really help holding each other accountable. And so one of the things that we quickly realized was, how are we going to say, hey, nursing team, hey, NPs, how are we going to get everybody on board to document on this checklist and be successful with it? And so we launched the Ultimate Taco Tuesday. There's a picture of us up there on 2/22/22. And we said we were going to talk about discharge. And so we really made it a fun in-service to really say, these are the things that we want to focus on. And this is why it's important and why everyone seems to be running into it. The other thing is, as you guys saw on that algorithm or on that acronym, there's lots of pieces to home safe. And there's lots of great ideas that can happen in a meeting. And one of the things that we learned very quickly was we didn't want our initiatives to compete with one another. So we gave the discharge checklist all of February, all of March. We wanted it to be kind of the shining star rather than trying to pull staff to different other pieces at the same time. And so as you can see here, the discharge checklist basically drops in for every baby. You type in home and it automatically pops up so that every provider can be able to access it. One thing that we learned very quickly is we wanted to avoid double documentation. And so it automatically crosses over the documentation that our nursing staff is already doing for things like newborn screens, CCHDs, car seat challenges. All of those things really tabulate immediately into there. And then one of the revisions that we actually made was the addition of row criteria. And so everyone always preaches, you have to have avenues for the staff to chime in, right? But then you have to listen to those things. And so one of the things that our staff nurses actually brought up was, hey, I'd really like to be able to advocate for my babies. I'd like to advocate for my families if I see something that's not done, but I may not remember all of the criteria that meet, a baby who needs a head ultrasound or a baby who needs ROP. What can you do? And so we ended up adding in something called row criteria. It pops up on the side. It tells you exactly what baby meets that criteria. And that created a different avenue for staff to feel involved. And so again, when we're in stretched bandwidth time, right? And so we looked at things like, okay, we didn't want to put this burden on just our nursing staff. So how can we divide that up? Well, we pulled in the other multidisciplinary team members on our team. And that was really having the OTs having a separate section that they could document, the pharmacist having a section where they could document the education and the medication teaching, since we do meds to beds, the fellow documenting handoff, so that it was a shared responsibility rather than this isn't done, where is the gap kind of happening. And so this is something that has been implemented throughout our hospital. It's actually also been extended to our other new level 2 unit. And it's been something that has allowed for better healthcare utilization. And so there's multiple kind of pieces through Home Safe. And as my colleagues have said earlier, it takes a village, right? And so I always want to give a special shout out to the Home Safe team, all of those dedicated individuals who respond to all of those numerous emails and meet monthly to really hash out how can we make it safer for families, because that's what it's all about. And so I always want to praise the fact that our UTMB NICU staff is open to those changes, and of course, always the staff and the families, the babies and the families, for helping us be able to provide avenues for them to chime in and to make it safer overall. Thank you so much.
Thank you so much, Dr. Franco-Fuenmayor, and thank you to all of our AAP Von Scholars for those presentations today. They were fantastic. I am actually going to have each of you put your cameras on, of our scholars, if you don't mind. And I've been keeping track of some of the questions that we've gotten through the chat. And so I can kind of direct you to some of those as we move along. But the first one is one that Dr. Myers asked that's actually directed to all of you. Since we are, I think, all working hard to try to be more intentional about involving families in our QI work, I'd really love to hear whether that's something that your teams were able to incorporate into the QI work that you're doing, or what barriers you've kind of found to doing so. And I'll let you guys just battle it out for who answers first.
I'm happy to speak to that one. One of our actually next PDSA cycles is involving members of our Family Advisory Council. And I think that, this team has been, going on for a few years, so maybe we're a few years too late, but they have been very, very, very helpful in the creation of a family Kamishibai card for, what role the family can play in prevention of an unplanned extubation. If you see something, say something to the team. If the tape seems to be loose, if and also guidance of, if you're going to kangaroo care with your baby, make sure to put distractions away and other things that they can do to kind of help prevent that during some high risk procedures. So I think it's very important. I wish we had actually involved them earlier, but that is one of the PDSA cycles we're working on next.
I can go next if that works. Sorry. I was gonna say, I feel bad since ours starts in the delivery room. We did not have families immediately involved, but I think now that we do all of our antenatal consults for all the moms that we can, we definitely kind of mention to them about our ways of trying to prevent chronic lung disease in our preterm population, and mention to them that babies, at our institution, we try and keep them on bubble CPAP till around 33 weeks at least, if we can. So we try and mention it to them about that ahead of time and work with them on that part. But yeah, I think we'll have to try and figure out a better way of trying to incorporate families early on. Or I do know sometimes families are do they really have to stay on this for that long? And get a little bit frustrated about the interface and stuff. So that'll be a good next step for us, I think.
I love that question, and I was really excited to see so much family focus at the conference a few weeks ago, and it really made me think about how we could involve for antibiotics as well. And I did speak back when we first created a multidisciplinary team with the nurses. I spoke with them about certainly mentioning to the parents, these are the antibiotics. This is what our goal is to take them off at an earlier time. And I think most parents are excited to hear a medication coming off earlier rather than later. So I do think they could be really vital to, keeping us honest and reminding us about that as well when we're on rounds. One small challenge, and kind of touching on a question that you asked as well, is that because our babies are born at other hospitals, most of the moms are still at the other hospital, and sometimes we'll have one other caregiver or parent that's available. But I do feel especially with parents coming from sometimes many hours away, we often don't see a heavy presence with our babies for their caregivers for often into the second day. So I wonder if that will affect us, but it is something I've been thinking about involving more, perhaps with a sign that says, if my baby is doing well, I can come off antibiotics in 36 hours, something like that, to involve the parents. I think that's a great idea. I really love that idea.
Yeah, I would agree. I didn't really think to involve families, because our project also took place in the delivery room, and it was just one intervention in the delivery room. But after kind of going to Vaughn and hearing all the families speak about how they were involved, I thought that was very interesting to have families involved. I know there are a lot of blogs and stuff about delayed cord clamping. So being able to provide that education to families would be pretty important. So going forward, that will definitely be something I'd like to get incorporated.
Yeah, I'll add to that. So one of the things for Home Safe as far as family involvement is we actually did a separate project because we felt so strongly about family involvement. That's actually Home Safe Family Care, and it really tackles all of the communications, as everyone on the same page. And the way that we kind of empowered our families to do that is that each baby now gets a NICU journal that's interactive at the front. The families can actually document on these, and then the back end is actually filled with education. There's a section of welcome to the NICU, development and nutrition, kind of those common problems that they'll face in prematurity, and then really a going home section. And so it's meant to put the empowerment in the parents' hands to say, hey, I was looking through the journal and I've read these things about, this is why you're talking to me about, hey, CPAP care, why is my baby on TPN? And so it really fosters that back and forth with the nursing staff and with the physicians about what are we doing. One of the things that we're actually going to be implementing is how do we get that parental engagement? We have lots of families who live very far away, and so we're trying to use either Zoom or in-person meetings to have what we are now launching as goals of care. and at set times when they're supposed to meet with us and really say, what are those barriers to discharge? What's going to happen for your baby to go home? What are the things that we need to do so that we're all on the same page? And the way that we're really collecting that data is really just getting a discharge survey to the families and just asking them, where are the gaps here? What do you feel is the biggest kind of hurdle that you faced when you were in the NICU? Because we find out many things when we're in the high risk clinic, but there's also lots of things that transpire during a very long hospitalization.
That's great. I think it's wonderful that all of you are thinking of ways to involve families if you haven't already. I think that, again, that's kind of the next hurdle for a lot of us in QI is making sure that that's a regular aspect of the planning of projects. I'm going to go through some of the questions that came through on the chat as well for each of you. So the first one I have for Dr. Ravi Kumar, it's from Amelia Garcia, and is your hospital also collecting labs from the umbilical cord of the delayed cord clamping upon admission? And if so, what labs are you collecting or prioritizing?
Right now, our hospital only collects arterial and venous cord gas for labs. We don't collect any other labs as far as I'm aware.
And one other question for you too, before I let you go, is how you worked with your L&D colleagues to really implement a workflow on this, because I know that's one of the struggles, especially as you're going into interdisciplinary type of QI, is how to kind of get everyone on the same page.
Yeah, so that's still an ongoing challenge from really both sides, the NICU and the labor and delivery teams, is remembering to do delayed cord clamping and discussing that prior to the delivery. I think one of the biggest challenges now is kind of working with our lower gestational babies, the comfort of monitoring those babies while they are waiting for the cord to be cut. I know our OB colleagues generally don't feel comfortable assessing, and historically our NICU teams and OB have been kind of in physical separate spaces. So kind of blurring the lines between our OB delivery rooms and where the NICU kind of hangs out, and making sure that the neonatologist is monitoring the baby or our NNPs are monitoring the baby during the delayed cord clamping, and then kind of communicating time intervals as well. So it's still an ongoing process. And there's been some kind of challenges that have come up, but it's been interesting to kind of work through that.
I bet. Dr. Anders, there was I think I actually asked a question for you. So I was wondering with your simulation, so I know that you said that you started with actual physical presence, I think, for simulations, and then have also had videos for staff. I kind of wonder whether there was a difference in satisfaction of staff, whether they did a in-person simulation versus watching a video, and whether you have had any COVID restrictions on being able to continue some of those in-person simulations with a lot of the, reducing numbers of people in rooms and things like that. I'm just curious how you've navigated that.
Yeah, that's a great question. So I end up doing some of the mock codes and stuff in the NICU, and then I think for nurses they have we call it like clinical decline scenarios that they have to do too. So I think like some of the times, like when COVID first started, they were limiting like how many people we could have. So we have a really great like Center for Education Development that some of them come and work with us on recording like simulations. So I feel bad. I think some of the times they've still had to use some of those since COVID's been going on. But I think now after the vaccine's been out, we've been having a little bit easier time actually doing mock codes and running through scenarios in person. So that's been a really nice change. I actually thought whenever we did the initial mock codes I'm sorry, not mock codes, but high fidelity simulations for doing NRP, I actually would just grab whichever team was on this, and then we would try it in different rooms and see which one was working. And I didn't realize with COVID, we actually had some of the regulators and stuff for using the different respiratory support, the companies weren't making them anymore. So it was one thing after another. So I thought actually doing the scenarios, running it with the high fidelity sim probably saved like a lot of babies from having trouble in the delivery room when we rolled it out, which was a nice change, I think, for us. But the nursing staff actually just keep like our like bubble CPAP like scenarios, like a QR code either on their phone or keep the video. So it makes it pretty easy for them. Because I don't know if other centers have had the same issue, but there was a lot of concern on our staff of like, well, how quickly can you switch between the support if the baby does go apneic or if they're bradycardic, how do we switch to PPV? And I think the more they've gotten used to it, it's become pretty easy to do, which I did not realize. Like I had been using it since fellowship. I got lucky that they were converting it and I didn't realize that would be a big concern when we first started. But I think it's helped a lot of people with comfort for that part. But
goes to show that you always find new challenges, right?
yeah.
As you're working on things. One other question is, I know you talked a little bit about, specifically the simulation and how that goes into play, but what other outcome and process measures are you following for your project in particular?
Yeah, so I think some of the balancing measures that we were looking at was of course, risks for like pneumothorax and nasal breakdown and things with the bubble CPAP use as opposed to, and I would say with the flexi trunk interface as opposed to the RAM interface, maybe the babies are getting a little bit more pressure with that. So we follow those. And then we actually follow several like process measures because with our guideline change, which was a huge change for us, we were trying to follow like some of the QI work that came out of Nationwide, where they're mainly keeping the babies on CPAP as opposed to like high flow or not if they're failing a Rumira trial. So we tried to do like keeping them on CPAP until a minimum of 33 weeks if they're on a PEEP of 5 and 21%. And then if they fail a Rumira trial, we keep them on again another week and do that until they're around 36 weeks, which was a huge change for our institution. And I think that part's definitely still a work in progress. It's not, I think we're still working on that part. So I'm hoping we'll continue to see improvement with, having that continuous pressure if they need some support, but definitely kind of working on those things. And lastly, we're also trying to look at our BPD definitions because there's a lot of different definitions out there, and looking at the paper out of 2019 from Jensen criteria where they kind of link outcomes with what type of support you're on. So we're definitely looking at that too. But
my last question for you is, with babies staying on bubble CPAP longer, because you said that was a big change. Have there been any differences in like length to accomplish PO feeding? I'm making an assumption that your institution doesn't feed PO feed while on CPAP, which may be a wrong assumption, but I'm just curious if you've seen changes with that.
yeah, so interestingly, and I think Colby, that's a great question. We're definitely looking at that also. That's like one of our other QIs. We do not currently feed on CPAP. We say if babies are on high flow, some of the physicians feel okay if they're breathing comfortably on like 2 liters or less, but we usually don't feed on CPAP. But I think overall our institution, like the length of stay has actually gone down, which has been kind of interesting. Just I think if they're needing support, we kind of give it to them, and then it seems like they're actually initiating feeds at similar rates. I'd have to verify all of our data, but yeah, I think we just actually looked at our length of stay data recently, and it's actually gone down since the last couple of years. So it's been a nice change, I think, for that part. So
that's great. Congratulations on it. It's hard to move length of stay. So good job. All right, Dr. Reinhardt, you're up for some questions. So there was one from, I'm sorry if I'm saying your name wrong, Shamila. And the question was, does your team perform CRE screening on your neonates? I don't know if you can.
Yes, we do. We do CRE screening and also MRSA screening on admission, and then every week. And when they turn positive, we stop, of course, but throughout their stay.
Perfect. And then I think Dr. Myers had another question for you too. He said, have you considered looking at medication reconciliation as part of this improvement work, since babies are coming from outside hospitals and these can contribute to incorrect timing of subsequent doses?
Yeah, absolutely. Couldn't agree more. Our next biggest PDSA cycle is really going to be looking at that the kind of focusing on the antibiotics that are given at the outside hospital, because I think that's really where we're getting a big chunk of antibiotics being given too much. I don't know exactly what the details are. My plan is to kind of investigate the process of what exactly happens when I'm there for an admission. Most often our transport team gives the kind of timing and doses to our residents and to our nurse practitioners. But truthfully, of course, I don't have the answer. I haven't thought of the answer. I have to investigate a little bit more, but I do think it has something to do with the med rec process or the kind of transfer of information or the discharge summary not coming through quick enough. I'm not sure where the breakdown is, but I do think it's somewhere in there. And then not kind of following the exact timing of the antibiotics and therefore giving too many hours or too many doses. So I think that's going to be really an important next step for us.
And where do you see things going in the future? Are you planning to transition to late onset sepsis as a new topic, or more interventions more on the side of early onset sepsis? I'm just curious next steps.
Yeah, I think when I think about the future of this project, I think getting down to probably moving my goal to another lower amount, because still when I think about most are probably getting somewhere along the lines of 12 hours in addition to what we already are at. So even getting closer, our babies really should be getting closer to 24 hours so that they're not, they're getting a total of 36. So truthfully, I think we just still have more work on the early onset. But when I started the project initially, my overall thought was to kind of attack early onset and then move on to late. There's also been a move, especially with the new guidelines for febrile neonates. So potentially kind of doing a similar project for those babies that come to our NICU. Some babies come to our NICU and some come to the floor. So it's very different, kind of just even depending on where you end up in our hospital, the number of days of antibiotics. So probably truthfully going to that before late onset sepsis, but I think it will be a progression of that.
That's great. Thank you.
Mhm.
All right, Dr. Tawari, I've got a couple for you as well. So there was a question by Sylvia Morales about what standardized ET tube taping or device did you use?
Yeah, so we actually use the H method of taping with a 3M tape, and 3M actually has like wonderful educational material on their website and on YouTube on how to do the H method of taping. And we had toyed with the idea of using a device, but really all the literature says that there isn't a difference between tape versus a securement device, as long as that really standardization is the most important. And that was the reason why we didn't move towards a device, but we used the 3M tape.
And just kind of stemming off of that question, so the education that you did for taping, is that your RTs in the unit that are doing all of the taping, or is it RNs as well?
Yeah, and that's actually changed a little bit over time. So I would say at the beginning of the project, our fellows were oftentimes like very present for retapes, and now it really there's been kind of a culture change, and really like the ownership of the tube is on the bedside nurse and the RT, and so they're the ones who do the taping regularly, which is great. So they were the ones who were the major targets for the education.
Fantastic. And then Amelia Garcia wrote a question. So regarding unplanned extubations, one of the questions or concerns that repeatedly gets brought up from their NICU staff and providers is the positioning of patients for the X-ray to determine the depth. And so she mentioned developmental aids like gel pillows, whether those are removed, whether the patient, if they're prone, is turned, versus that idea of taking the X-ray as the patient is living so that you really see what's going on, as opposed to putting them in the optimal position and then maybe not staying.
No, for sure. We're working on a pictorial and a checklist that's going to be essentially performed between the radiology techs and the bedside nurses to standardize the positioning of the infant with with an ET tube and central lines with all the devices removed. Is what we're opting to do. But the argument to shoot an X-ray in the natural position of the baby is definitely well taken. It's difficult because supine prone, and then sometimes with these devices you are not able to get a good view of your central lines and things of that nature. One of the things we've also done is we've we started annotating the x-rays. So the radiology tech will actually write the depth on the film, and it'll get visually verified by the radiology tech and the bedside nurse at the time right prior to shooting the film. And so it's helpful to know that information like days later when you're reviewing an x-ray to be like, okay, it was in perfect position at 9 centimeters 3 days ago. But it's a good question, and I don't think there's a right answer for it, but we've opted to at least standardize the positioning of the babies.
And that's probably the key, right? It seems like the key with most things with QI, as long as you can get good at doing it the same way, then hopefully that'll be an improvement. I had asked a question too about your chart showing unplanned extubations per event days of why you thought you had that increase in the center line. I think it was in maybe like July or so.
Yeah.
And I think Jeff had made a comment as well about whether it was based on maybe not as much baseline data prior versus the inline suctioning. I'm just curious your thoughts.
Yeah, no, it's a really good question. And I think that, yeah, Dr. Ryan definitely makes a great point because we only had 6 points in our baseline data, and that was really a limitation of our EMR. We weren't able to collect ventilator days prior to that period. We looked at, Dr. Ryan also mentioned whether or not it was like a change of acuity in terms of patients, but we've looked at that and followed it for other projects in terms of like mean gestational age, birth weight of babies, and really the acuity doesn't seem to have changed over time. So I don't think that that's a reason for it. If the center line change is real, I think it's twofold. I think we honestly were just capturing the data better because prior to this, we were just doing a manual collection of this data. Our neonatal fellows would do it monthly. And then once we created this redundant process and had the bedside nurses entering it into the medical error system, the error reporting system, the RTs would fill out the ACA forms and the fellows would manually collect it. I think that our baseline data may have just been closer to the 4.7 per 100 ventilator days. And then the frontline staff at that time also really attributed the weight of the inline suctioning that was started to really have also contributed to events during that kind of acute period. And that's why we did some targeted in-services from the vendors on that.
And you've had some impressive improvements over time. What do you think is your best, like your number one intervention that you think has really improved things in your unit?
Yeah, I think I would say there's probably been 2. The first one I think was definitely the RT ventilator like audits. I think just like the Hawthorne effect with people just knowing they're being watched and kind of compliance. You know, when staff was recognizing that they're being observed, it really made a difference in terms of people being on top of the tubes being secured and making sure that we were, you know, really on top of that. And then I would say the debrief guide, because that really helped, and that was in cycle 5, that really helped with compliance with just conducting like an in situ analysis of the event by giving like the frontline providers streamlined questions to ask, and really helped kind of create like a shared mental model in real time about the risk factors that contribute to an event. So I would say those are our 2 highest probably impact interventions.
Well done. Very impressive.
Great, thank you.
Of course. All right, Dr. Franco-Fuenmayor, you're the next one for questions. You got a shout out, it looks like, from Jeff Myers about your acronym. So good job with that. And then Mary Lewis had asked a question. She said, is your discharge checklist paper or electronic? And if electronic, does it transfer documentation from other areas of the EMR?
It is completely electronic and it crosses over from other pieces. And so that was big. We wanted to make sure we didn't do double documentation. And so there's certain pieces, we call ours daily cares, where the nurses are actually putting in their newborn screen. It automatically flips over to do that. I've also been told by IT that now that it is an official flow sheet, it is in the Epic universe. So for hospitals that use Epic, it is apparently accessible.
That is a great point. I think you may have a lot of centers stealing it from what I saw, because it looks pretty fantastic. What about for caregiver education? So what kind of cycles or interventions have you implemented to make sure that you have longitudinal education for caregivers and for parents to really stay involved?
Yeah, and so, I mean, I feel like this is the one thing that everyone kind of struggles in their unit. There's different barriers to having families at bedside or also constantly being there. And so the journals have helped with this. We actually track who's getting the journals, are they actually accessing it? And with this new parent discharge survey that we're launching, it actually has a question directed to the families. It says, you know, did you get teaching from this journal? And how comfortable did you feel feeding your baby? How comfortable did you feel hooking up the baby's oxygen? All of those, is this something that happened throughout the hospitalization, or was it, hey, you're ready to pick up your baby? Let me teach you everything about them in about 10 minutes. Because we know that unfortunately that can happen. And so we've logged that in, and with being able to incorporate those journals, we've also gotten lots more questions from the families about, well, what are the things that my baby's doing? Is this normal? Is this not normal? And it really serves as a really good teaching moment for the staff to really bring it back and say, hey, we just did ROP screening. Here's how your baby's doing. And oh, here's a little bit more about this and what to look for. We found when we were querying the families in the high-risk preemie clinic that those items that we've implemented over the past year have been really successful as far as them feeling comfortable in doing that. And a lot of the families asked for these goals of care conversations. And so that's why we're going to be launching that.
And who owns the discharge checklist in your unit? And I ask that because I feel like there's so many projects that are fantastically done and then can somewhat go by the wayside if there's too many individuals that can contribute to them, but not necessarily one person who is responsible ultimately. And I'm curious, in your institution, who owns making sure that's done?
Yeah, so our clinical nurse educator and our discharge planner share it. And so when things are being popped in, when we are rounding, we actually bring it up. We're like, okay, well, what are the barriers for this kid to go home? And now that there's a flow sheet, everyone can look at it very quickly and be like, oh, this is what we're missing. This is what we're not. We also have it automatically drop in as a smart phrase in our EPIC discharge summary. So when our NPs are actually putting in a discharge summary, we can tell whether it's been filled out or not. And actually look that way. So it's really nice that you see these kids followed up in clinic and you see that whole checklist just drop in. And so that's what we found has been most useful because there's so many people documenting.
Have you had any of the community general pediatricians involved in your work? Because I would assume that some of our discharge summaries might be less than ideal. I mean, as a group of neonatologists for pediatricians in the community. And I feel like this would be something that would be hugely helpful for especially a long-term stay baby who's presenting for the first time in clinic. And I wonder if it's a group that I don't frequently think about involving necessarily. And so I'm curious if you did.
Yeah, that's a great question. One of the things that we did is that when we actually rolled out these discharge algorithms, we kind of figured out, well, who's the majority of specialists and like outpatient pediatricians that these kids are going to, and we met with all of them. And we actually got their feedback. And so, the closest counterpart to the high-risk preemie clinic is the complex care clinic. And so they see kids for 2 years and up. And so they may see some of our kiddos. And one of the things that they asked us for was a handoff. They're like, you guys have known these kids for months. How can I learn them? And, this like 8 and 9 month stay in this limited clinic slot. And so the fact that like now the fellow drops in a handoff has made it very easy for them to log in. It's under a set note type. They don't have to dig through the chart. They just put it in and it automatically pops up. And that has been really helpful in getting buy-in. The other buy-in has been with the different subspecialists, particularly cardiology. If we're following kiddos with like pulmonary hypertension, or we're following kids on CHF meds, and really honing in, we sat down and we met and said, let's look at these time frames. This is what the neos want. What do y'all want? And so that we could hit a compromise so that we weren't putting kids in appointments or clinics that they really didn't need. One of the first things back in 2020 was we saw a lot of kids were getting referred to both any clinic and complex care clinic. And so that's healthcare waste, because there's, you want the best clinic to follow that kid who has those resources. And so we laid it out. We're an academic institution. Our residents now know what to do. We've disseminated the algorithms to the community pediatricians and all of the mid-level providers. And so they know, hey, this kid goes to preemie clinic because of XYZ. This kid goes to complex care. What are the timeframes that I should follow them, especially if there's readmissions and any of those appointment times get shifted. And that really has, created a wonderful way, because you have less appointments for the families. You have less no-show rates in your clinic. You have happier subspecialists and happier community pediatricians. And so we felt that was probably the best way to tackle that.
I have one more question for Dr. Franco-Fuenmayor. So if anyone has a burning question they want to ask, you have to get it into the chat in like the next 30 seconds or so. But my last question for you is actually from Dr. Horvar, and it has to do with addressing social determinants of health in your project, and whether there's a way to address follow through for those social determinants of health if there's been needs identified, or if that's been kind of incorporated into your thought process as well.
Yeah, so that's a great question. It's weaved in to our project. And so our social workers are actually part of this home safe team. They see every baby admitted to the NICU, and we've rolled out parent resources that they give on each consult. And so we're partnered with an organization called Hand to Hold that gives resources to families. And so each of our families gets that brochure right on their first consult, which is usually in the first 24 to 48 hours after they've delivered. And then they follow them throughout. They have this care manager like assessment note that is like, you know, are we having issues with transportations? Which family qualifies for Medicaid transportation? Which family can't come in because of a certain barrier of X, Y, and Z? You know, does that mom need resources in getting all of that done? And so it's weaved in different places. The other thing that I don't know if it's widely shared as far as resources for our moms is there's actually a national helpline for moms. It's 24/7. It's in English and Spanish. And so our social workers now give it to every mom, regardless of what's going on in their NICU stay.
That's fantastic. Thank you. There have been multiple questions coming through too about whether any of you would be willing to share some of your guidelines that you've pulled together in resources. And so I have those kind of set aside and can ask you offline and figure out a way to get those out to the VON listserv if that's okay. But I really want to thank all of you so much for your presentations. You've done absolutely fantastic work. You absolutely deserved your AAP VON Scholar designation, and I think we're going to see wonderful things from all of you to come. So thank you so much. And I think that's it from me. Thank you guys all for joining. We'll plan on hopefully having this as an annual virtual conference. So thank you.